So it's my privilege today to introduce somebody you've heard from already today, and you'll hear more from before the sessions are over at the Ed Forum, Dr. Judith Trotman. And she was earlier introduced with her title at Head of Hematology at Concord Repatriation Hospital at the University of Sydney in Australia. She has an extensive bio with wonderful details about all the things she does, but what I really noticed in reading it is that in almost all cases, she is showing leadership, leadership in research, leadership in formulating clinical trials and supporting their patients and participation. And so obviously she's made a real difference in the business of treating WM. And she's been focused on WM, although she does more work than that for sure. But what I think is probably a distinguishing thing for Dr. Trotman is she clearly gets the award for the speaker having traveled the greatest distance coming from Australia to be with us. So with that, I'll just turn it over to Dr. Trotman.
Thank you very, very much. It's a real pleasure to be here. I have to say, I don't think I'm going to come back to Seattle again, though, because I'm told I've seen it in its finest, and I'd like to keep those marvelous memories of a beautiful city. So it's interesting that I was given this topic. Pick your poison. Oh, sorry, IT guys, I wasn't supposed to pull that up. Pick your poison, and I want to remind you all that pick your poison is a term used for making a choice between two undesirable options. And so I thought, well, that's fair enough, but we should also be a little bit more optimistic. And so I've added my own title, Playing the Long Game, because I do think that you do need to be thinking about the decision-making in terms of longevity and sequencing of therapies. I'd like to note there I have trials funding to my institution, in particular from PCYC or Janssen as an investigator in the Innovate study, and then from Beijing as an investigator in their studies in Waldenstrom's. But no personal financial conflicts. And also thank the slides that Dr. Paludo presented last year were so good. I've taken a number of them as scaffold for this talk. We're going to review the current treatment options, focus a little bit on emerging therapies and clinical trials, but not too much because I understand you're going to get a talk on that later, and trying not to be too much of a zealot, but encourage you to consider participation in clinical trials. So I guess chemotherapy was last century. Chemotherapy alone. I think the advent of rituximab, the anti-CD20 antibody, in 1998 and subsequently, was a real revolution in the care of patients for Waldenstrom's in being able to add rituximab to that chemotherapy. But for me personally, as a Waldenstrom's doctor, the moment for me was the end of FCR in 2004, when I no longer had to use this terribly immune suppressive chemotherapy combination in my patients, when we were allowed to start using dexamethasone, rituximab and cyclophosphamide on the basis of the data from Athens, and then subsequently bendamustine and rituximab. So that combination immuno, meaning antibody, and chemotherapy approach. And those two regimens are still very much the pillar immunochemotherapy approaches for Waldenstrom's that I will discuss in greater detail. But there's no doubt as well that the advent of the BTK inhibitor ibrutinib was a real game changer, and then the subsequent second generation BTK inhibitors as well. So what treatments do patients get? And I think the most wonderful thing about the Whimsical Patient Registry, and I do hope you will all join Whimsical and iteratively at a few settings over a cup of tea, start entering your own data into this global registry. Because you are now telling us what the treatment patterns are around the world. So I can say to Dr. Ansell as much as I like, well, I always use BR or whatever, but it's my patients who put their data into the registry that really say what Australian doctors are using in terms of treatment for Waldenstrom's. It's interesting in Whimsical, we're echoing the data that we get from registries. The median age at diagnosis is 62, mostly men, mostly white men. The median number of lines of treatment is 1, and that IQR is what we call the interquartile range, the middle 50% of patients. So the middle 50% of patients receive 1 to 2 lines of therapy. And in our sunburst chart on the bottom corner there from Whimsical, you'd be amazed that, there are actually a couple of patients there who've had 10 different lines of therapy. But for the majority of patients, it's just 1, 2, or sometimes 3. And 18% of the patients who are participating in Whimsical are still undergoing a watch and wait observation approach. But there are numerous first-line treatments, and before 2016, rituximab monotherapy was the most common one used. Rituximab in combination with cyclophosphamide was the second most common, and then in combination with bendamustine or dexamethasone, rituximab, and cyclophosphamide. Fludarabine-based treatments were still reasonably commonly used before 2016, but after 2016, of 233 first-line treatments, you can see the marked increase in the use of bendamustine and rituximab as first-line treatment, and the advent of the BTK inhibitors as well, with a lower reliance on rituximab monotherapy on its own, and the use of dexamethasone rituximab in combination with cyclophosphamide. And pleasingly for me, and I must admit I'm not someone who's used a lot of bortezomib, the proteasome inhibitor, I am, however, pleased that it's not included in the first-line therapy because of its particular toxicity with neuropathy. So I think what is very important, where possible, is not just a second opinion, but you heard us all up the front here, and you effectively got 4 nuanced opinions. And that's why I think the multidisciplinary team review of your diagnosis, making sure you get the diagnosis right, and it is indeed Waldenstrom's, not marginal zone or some other lymphoproliferative disorder. Good pathology review, good radiology review is so important, and in Australia we call that the multidisciplinary team meeting. I understand in the US it's a tumour board. But I would be saying when you're diagnosed, is my case going to be presented at a tumour board, and could I potentially get the outcomes from that? So in terms of the classification of treatment options, I've already, and you're all very familiar with the chemo-immunotherapy combinations, and they tend to be of a very fixed duration. So DRC will go for 6 cycles for about 4 months, and bendamustine rituximab for 6 cycles over 6 months. If you combine rituximab with any of those proteasome inhibitor therapies, it's listed down there. But then you move on to more continuous therapies, which are the targeted therapies, the BTK inhibitors, which end in nib, either zanubrutinib, acalabrutinib, or ibrutinib. And then later the BCL2 inhibitors. And the way I think of describe these targeted therapies to my patients is that it's like a switch. It's like a light switch. And you will switch off the activity of the Waldenstroms so long as you keep taking it. But when you stop it, eventually, it might not happen in the first week or 2 or 3, but eventually I expect that it will come back again. And so it's taking your disease-controlling agent just as if you were taking your blood pressure tablet, and turning this disease into a chronic, manageable condition. So let's get down and deep into the commonly used treatments. And the first is my preferred treatment for the young, fit patient in whom I'm aiming for the deepest, most durable response in ideally a most rapid time. And this is an intravenous infusion. The rituximab and the bendamustine are given on day 1 and the bendamustine alone on day 2. So it's 2 days of bendamustine every month for 6 cycles. And virtually everyone will respond to bendamustine rituximab. Most people will get a major response with at least a 50% reduction in their IgM level, and you will see their hemoglobin and their IgM mirror image, and I've got some examples of that. And it tends to usually last for a good 6 years. There is significant debate that you heard us allude to up the front over the dose and the duration. And I must admit I'm a bit of a purist, and I tend to say I start bendamustine and rituximab in someone in whom I expect to give them the full 6 cycles of therapy. Now, I may not be able to deliver that, the full 6 cycles at full dose, but that's the patient population in whom I opt for bendamustine and rituximab, whereas the other patient who I consider is not fit enough for that, but is still fit enough for immunochemotherapy, I will give them dexamethasone, rituximab, and cyclophosphamide. And that's my rather simple way of approaching it, because I don't believe we have really robust, and I know we don't have robust prospective data comparing 70 milligram per metre squared versus 90 milligram per metre squared of rituximab, 4 cycles versus 6 cycles. And I think it would be perhaps incorrect to make assumptions that just because someone has had a lower dose, they are still going to get the same bang for their buck, but not as profound immune suppression. You know, it's that whole, grandma tells you can't have your cake and eat it too. You can't expect that you're going to have as good a response to your Waldenstroms at the same time as reducing the toxicity of therapy. There are common side effects that occur with bendamustine. You've heard about the low blood count, the neutropenia, which to me almost seems inevitable. After about 4 cycles, patients will get a little bit neutropenic, and we give them the colony-stimulating factor, the hormone-like injection that we all produce to encourage our neutrophils to recover after chemotherapy. We just give that in bigger doses, little injections under the skin to support the neutrophil counts as we go through the treatments. And many of you, in fact, one day, can I make a vote for next, in 2 years' time? I think you should have a talk about rituximab infusional reactions. And I think you guys should give the talk, all right? Because I'm sure there are many experts in the room, and I reckon that's something that the IWMF should be getting some good data about. In fact, we'll probably get we'll look deep into the whimsical data and see how many of you have had rituximab reactions, because that is such a common thing that occurs in patients with Waldenstroms, not necessarily just in the first dose, but can occur any time. You may have had rituximab, 3 different times over 20 years, and then suddenly, lo and behold, you have an infusional reaction on your 4th dose, the 4th time you have it. And there are some tricks that we all have to help manage that. And I'm going to move on because I'm talking too slowly, sorry. So this is an example of a classic patient in whom I will give rituximab and bendamustine. This 60-year-old manager is working full-time. He's very fatigued. He has joint aches. His hemoglobin is 10 grams per decilitre. I've kept my numbers here that we use in Australia because I've got the graphs from Australia. So you can see his hemoglobin down there. Does this pointer actually work? Can you see? We've got 2. All right, which one are you going to go to? We'll go to the right. Okay, so his hemoglobin's 10 grams per decilitre and his IgM is 36,000. And you can see with his 6 cycles of bendamustine rituximab how nicely his hemoglobin has come up and how quickly his IgM has come down. He did need GCSF for his low neutrophil count on cycle, and that's actually cycle 5. I tell a lie. I sent these slides to my patients just to check with them that they had their consent to present their data, even though it's de-identified, and he did correct me. It was actually cycle 5 when he needed his GCSF. But it was very well tolerated with no infections. And his hemoglobin came up, as you can see, to the normal range, and his IgM is 2 grams per litre. And in retrospect, he says, yeah, you're right, I was more tired than I thought I was before treatment. Moving on to DRC is the more gentler chemotherapy, and the one that I like to use when I'm aiming for low toxicity in the less fit patients. It's given intravenously every 3 weeks, and then there are the oral cyclophosphamide tablets as well that patients take for 5 days. And it has a slightly lower overall response rate and a slightly lower duration of response. Now, the way we measure duration of response in our drug registration trials is called progression-free survival. And that is defined by progression of the disease. So, for example, in Waldenstrom's, if the IgM1 marker of progression, the most common marker of progression is if your IgM goes up by 5 grams per litre. Progression of disease or death. Now, that might not be from Waldenstrom's, it might be death from another cause. And that progression-free survival is a very important factor to remember, that includes death, given that dying of other causes is something that patients with Waldenstrom's will often have. There are the same similar side effects that you have with bendamustine and rituximab, with bendamustine, just not the same profound cytopenias, the same profoundly low blood counts and increased risk of infections. So when I decide, am I going to give bendamustine rituximab first line, or am I going to give dexamethasone rituximab, I have to consider the patient's life expectancy as well as their desires, how much they want to push through with their chemotherapy. And this is a woman who, when she came to me, she was 78, but her Waldenstrom's had been diagnosed in 2016 when her IgM was 8 grams per litre. And it's really helpful, really helpful. I always try and get my patients to dig out any old bloods, because they'll always have a total protein even if they haven't got an IgM. And that helps me work out the tempo of their disease, which is so important when choosing your treatment. And when she was referred in 2000, her hemoglobin was nicely in the normal range, and her IgM was, I can't see it there, what was it, about 27, so 2,700 milligrams per decilitre, and she was very fit, although she did have what we call moderate aortic stenosis, so narrowing of her heart valve called the aorta. And in early 2022, in the middle of the COVID pandemic, she started noting she was getting fatigued when walking up hills, and you can see there, watching the tempo of her disease, the hemoglobin is trending down. It's not that magic 100 grams per litre where we often say is a marker for starting treatment, but her IgM is going up to 45 grams per litre, if you'll let me continue to describe the figures that I know. And it's the combination of that anemia and the raised IgM that is starting to contribute to her exercise intolerance. And so we decided we would give her dexamethasone, rituximab, and cyclophosphamide as a fixed duration therapy in the midst of the Omicron wave. And you can see how nicely her IgM started coming down, and how her hemoglobin, and I can tell you now it's now right up in the normal range. So a much less commonly used treatment, as I've shown you now, is rituximab monotherapy, but a number of you would have had rituximab on its own. To me, I prefer the synergy of rituximab with chemotherapy, even if it's only a small dose of cyclophosphamide and some oral dexamethasone, because I do believe you do get better responses and longer responses. But we do sometimes now consider using rituximab for the immune-driven hemolytic anemia, red cell destruction of cells by antibodies, which causes anemia. And some people, I do sometimes use it for patients with an IgM-based neuropathy to see if we can try and stabilize the progression of their neuropathy. I've never seen it go away with rituximab monotherapy, but sometimes, maybe in about a third or a quarter of patients, you can have stabilization of progression. And then came along ibrutinib, and I have to say, as a hematologist, it was a real privilege, an absolute privilege, to be participating in the INNOVATE trial, where patients were randomized to either ibrutinib and rituximab compared to rituximab monotherapy, which was then considered a reasonable standard of care for the treatment of Waldenstrom's. Now, the obvious lack in this trial was the fact that there wasn't a third arm of ibrutinib on its own. And I do suspect that there is not quite the same added value when you add rituximab to a BTK inhibitor as when you add it to chemotherapy. But ibrutinib was a first-in-class enzyme inhibitor, and what it does is it inhibits the bruton tyrosine kinase enzyme inside the cell that is driving the proliferation of the Waldenstrom's cells and their prolonged survival. And it literally is a switch. It's well tolerated, but there are common side effects that many of you will know very well. And there is significant bruising, mostly on the arms and hands, but very much less commonly there is a rate of severe serious infection, serious bleeding. Low blood counts are common, joint pains, and as you've all heard, the atrial fibrillation is more common with ibrutinib than with the second-generation BTK inhibitors. And hypertension, after you've been taking ibrutinib for some years, you'll start seeing a significant rate of hypertension. But we also have to accept that we are all getting older, and atrial fibrillation and hypertension. Atrial fibrillation occurs in 70% of otherwise, people in their 80s who don't have Waldenstrom's. So we need to just always remember there's a background rate of atrial fibrillation and hypertension. And it has a very good response rate, and the duration of response, we're really not sure exactly what the median duration of response is with ibrutinib. It may well be more than that 39 months that I've listed there. And because you need to start slicing and dicing it in terms of people by their mutation status. So the best risk population, the patients who are mid-88 mutated and CXCR4 wild type, so the 70% of patients with Waldenstrom's who are CXCR4 wild type will have a 5-year progression-free survival of 70%. Ibrutinib is the first in class, but there has been a phase 3, a randomized clinical trial comparing ibrutinib with zanubrutinib that makes it clear to me it's not the best in class. However, for patients who are on ibrutinib and who are tolerating it well, there is no way you would want to switch your BTK inhibitor. It's working well for you, so stick with it. And there is definitely evidence now that we've seen that dose reductions for intolerance, which are actually done more commonly in women, suggesting there's a gender issue there in terms of what the right dose should have been, but particularly those who are elderly, that dose reduction does not impair disease control. In fact, outcomes were a little bit better in the patients who had dose reductions for intolerance. So I strongly recommend that if it's working for you, stick with it. Zanubrutinib is my preferred BTK inhibitor. It's efficacious and tolerable. we have better, very good partial response rates, and that is defined by more than 90% reduction in the IgM level. So that's at the 4-year follow-up of the ASPEN study, that's VGPR rate is 38% compared to 25%. Now that, however, is not the most important advantage of zanubrutinib. And to be honest, I initially refused to participate in the ASPEN study because I still had patients getting zanubrutinib in the phase 2 study, and I'd had my experience with ibrutinib in INNOVATE, I'd had my experience with zanubrutinib in the 003 study, and I knew which BTK inhibitor was the better tolerated BTK inhibitor. So I felt, no thanks, but no thanks. I don't want to randomize my patient. Let someone else down the road and participate in the trial and get access to zanubrutinib or ibrutinib for their patients. So I sort of pretty much made up my mind. Zanubrutinib can be given twice a day or once a day. It probably doesn't matter whether you take 2 in the morning, 2 in the evening, or 4 once a day. And like ibrutinib, it is a switch. You will have a very good response to zanubrutinib. But to me, the most important advantage of zanubrutinib is the quality of life improvements in comparison to ibrutinib, with lower rates of bruising, lower rates of nausea, lower rates of diarrhea. You know, having a bowel motion 2 or 3 times a day is very socially disabling for a lot of people in terms of being out and about around town. Lower rates of hypertension and fewer cardiac effects. We all focus on the atrial fibrillation, but there is very rare ventricular tachycardias that are quite significant and obviously life-threatening in patients on ibrutinib. And as evidence of the better tolerance, the discontinuation rate is only 9 compared to 21%. The other thing I like about zanubrutinib is that the patients who are MYD88 wild type and the patients who are CXCR4 mutated seem to have, when you're doing cross-trial comparisons, seem to have a better response to zanubrutinib. And the 4-year progression-free survival is 78%. So here is my frail 84-year-old man with chronic sinusitis and heart issues, and his Waldenstrom's was diagnosed in 2009. He was watched and waited until 2020 and had 1 cycle of rituximab and bendamustine at the age of 80 and swore he would never have it again. So he only had 2 doses of bendamustine. Having said that, didn't it work well for him? It worked very, very nicely, just that 1 cycle for quite a while. He was referred to me in 2021, and with symptomatic progression, and you can see his hemoglobin gradually dropping and his IgM gradually coming up over the next 18 months, 2 years. And the symptoms of fatigue and breathlessness, we started him on zanubrutinib. And you can see, I've witnessed this with the zanubrutinib, they get there with ibrutinib, they get there just a little bit faster with zanubrutinib. And to be honest, it doesn't really matter. That's not, for me, the defining difference between the 2 drugs. It's the tolerance. And he had a rapid improvement in his exercise tolerance and just has short pauses for 4 days for skin cancer removal, which unfortunately is the happens in just about every single Waldenstrom's patient I have in Australia who has significant sun exposure in the era before sunblock. And when he looked at this slide, he said, "You've got to tell him I'm back at bowls." So there you go. He's very happy that he's back bowling. He's got the energy for that. So my preferred first-line treatment for most patients is rituximab chemotherapy. Bendamustine rituximab for the younger, fitter, and DRC for the older with a life expectancy of greater than 7 years. But if their life expectancy is less than 7 years because of other comorbidities, I do choose zanubrutinib because for me it's the closest to what I describe as a set-and-forget medicine, which is so well tolerated, although I do have to monitor them initially in the first few months a bit more closely for low neutrophils. And conscious of the time, I'm going to whip past, but you can see here, it's very interesting, and this is why I want hundreds more of you to join into the whimsical study, so we can see which is going to be the winner between bendamustine rituximab and BTK inhibitors in terms of the time to next treatment, which to me, I think, is a more important endpoint than progression-free survival for patients. So, progression-free survival, I've said, is based on that 5 gram per litre rise in the IgM level, and the Dutch have done their discrete choice experiment study and noted that that is the number one patient priority. But I wonder if patients really knew what progression-free survival meant, that I would argue that time to next treatment and quality of life are as or more relevant for patients. And it would be wonderful if we could devise a WM-specific health utility index akin to the quality adjusted life year that incorporates the impact of both quantity and quality of life for economic evaluation. I argue that we shouldn't abdicate our responsibility to our funders to work out qualities. We, with the patient community, should be working out some sort of utility index. But of course, how on earth would we derive such a utility measure on which a group of clinicians, statisticians, and patients would substantially agree? So I'm just now going to whip through another case study that to me illustrates the importance of the long game. This gentleman presented to me in 2004 at the age of 49. He had some mild leg cramps and the occasional night sweat. What is interesting, we know 7% at least of patients will have a family history of other B-cell malignancies like this man. And his bone marrow biopsy shown there had 40% infiltration with Waldenstrom's. And I educated him about watch and wait, and we would sort of said that probably would treat you when your hemoglobin started approaching 10 grams per deciliter, or your IgM was 5,000 milligrams per deciliter, so that we could accommodate any IgM flare that occurred with rituximab, but that we would do that decision about treatment based around your social and employment priorities. He did have treatment after 2 years of watch and wait, you can see there, and I just read the abstract by Meletios Demopoulos at a conference suggesting this novel treatment of dexamethasone, rituximab, and cyclophosphamide, which didn't have the stem cell toxicity of the oral chlorambucil. He tolerated it very well. You'll note he had a little IgM flare, because this is when we started him and his IgM went up with the treatment, but he had a very good partial response, which lasted for 10 years, and then he had progressive disease over the next 2 years. And in 2018, we gave him DRC again. It was less well tolerated with recurrent sinusitis, but he got another 4 years of very good partial response. During COVID, he retired to the south coast of New South Wales, and one wonderful legacy of COVID was telehealth appointments. So he continues to see me via telehealth, and while it's not my laboratory that measures his results, he's entered his results into Whimsical. And in 2023, with recurrent sweats and fatigue and his IgM going up, not as high as it did originally, not as high as it did second time, but in addition, he had a very low albumin, which to me is an important marker of health and nutrition and fitness, and itself another reason why I wanted to start treating this man. And he commenced zanubrutinib, his IgM came down, and he became asymptomatic within a week. He does have some mild hand bruising. There is still bruising in patients, a number of patients with zanubrutinib, just not to the same degree. So this 68-year-old has been treated twice with DCR, is now on zanubrutinib with an excellent quality of life. Of course, he, like everyone else on zanubrutinib, the pioneers, they start a drug and you don't know how long it's going to last for, and they keep saying, well, how long is it going to last for? And I say, well, you're one of the first ones. I can't, you're going to tell me. But I keep reminding patients that, patients with WM die from secondary cancers. We see a lot more prostate cancer. I've seen people with colon cancer, breast cancer with WM, and and other vascular causes as often as from their WM. And he wants to live to 85. And I'm thinking, well, okay, we'll try. Pirtobrutinib, sonrotoclax, BTK degraders, maybe they'll help us there. So let's talk briefly about these potential new therapies and the fact that there are also novel combinations of established treatments being trialled. But there are, I'll flick on to the next slide, there are other covalent BTK inhibitors, tirabrutinib or elabrutinib being developed in Asia. Acalabrutinib is another extremely well-tolerated oral BTK inhibitor that is available in some jurisdictions. I've used it for other diseases. I'm not allowed to use it for WM in Australia, and I do get a bit frustrated with the mild headache, but then patients can take it with a cup of coffee and that seems to settle it down. The non-covalent BTK inhibitors have about 2/3 of patients will respond to pirtobrutinib, even if they have had a previous exposure to a covalent BTK inhibitor. And so this is a really promising agent. Unfortunately, I don't know how much you can get access to pirtobrutinib in the US. Thank you for your feedback. Because, and even in the compassionate access schedule, I think we all leapt on these compassionate access programs and created a huge drug supply issue globally. So unfortunately that has shut down. But hopefully that will become available in the future with a similar side effect profile to the other BTK inhibitors. Why have we frozen? Oh, there we go. Okay. So there are these other enzyme inhibitors called BCL2 enzyme inhibitors that are used in other B-cell lymphoproliferative disorders. And venetoclax is not yet approved in any country. Here is the publication from Jorge Castillo's presentation. And you can see that, patients will have it sort of looks like a good sort of 2-year progression-free survival, and then things tend to drop off. I mean, there's not too many patients in this study, so we've got pretty wide confidence intervals there. But most people will respond to oral venetoclax. My personal experience with venetoclax is that I don't have a sense that it has as deep a response in terms of the reduction in IgM level and improvement in hemoglobin as you see with the BTK inhibitor. But I think it synergizes very, very well with rituximab. And so I have had a few patients who said, I'm not having rituximab again. And I've said, yes, you are. We're going to work this one out. I said, if you're going to have this venetoclax and you've only had a minor response, well, then you'll promise me, won't you, that we'll sneak a little bit of rituximab into you and I'll dose you up with lots of steroids. And sure enough, both of them have been very, very happy to have had the synergy of rituximab with their venetoclax and have tolerated rituximab very well. And in that situation, it's the one situation where I actually use a maintenance rituximab program in patients who have had venetoclax. And we've now got access to the second generation BCL2 inhibitor, sonrotoclax, in clinical trials. I don't know it's going to be such a game changer in the same way that zanubrutinib was with ibrutinib, because as I said, zanubrutinib was a game changer primarily because of the improved tolerance profile. Venetoclax is a very well tolerated drug, so it'll be interesting to see. The one extra thing I do want to talk about is the very promising mechanism of action of the protein degraders, as opposed to inhibiting the BTK enzyme, actually degrading the enzyme. And we've got 4 patients in this trial who are doing very well. The bispecific T-cell engagers are being studied, alternative antibodies and cellular therapies that I'm sure you'll all hear about. And then the iopofosine, I can never pronounce it, is a very effective, has just had an announcement about a very high major response rate in patients, but because it is a radioconjugate that targets lipid rafts in the Waldenstrom cells, there is some innocent bystander effect on the other blood-forming cells in the bone marrow. So patients generally do need platelet transfusion and red cell transfusion support in the weeks after they've received this radioimmunoconjugate. And I just want to remind you that there are some things that we shouldn't be trialling again in Waldenstrom's. When we had 2 patients with tislelizumab, a PD-1 antibody, who had profound autoimmune hemolysis that was, was really quite scary for us, we stopped the studies of tislelizumab. Fortunately, both patients recovered on the zanubrutinib alone. We've shown that venetoclax and ibrutinib might work very well at bringing your IgM down, but there are way too many cardiac toxicities to be combining these 2 agents. So it reminds us again of the importance of robust clinical trials where safety is always the #1 priority. And with that, I'm going to just point out that there's many, many years. We can appreciate your frustration, but there is a very long time in drug development over years. And even after drugs have been released, as we all remember from the thalidomide story, post-market surveillance is very important. A good clinical trial will ask the right question, it's ethically justifiable and conducted ethically according to the very strict code of good clinical practice. And this allows our laboratory breakthroughs to be translated into the clinic. And why would you participate? Because of the direct benefit to you from the studied therapy, and even when the treatment is standard, even if you were randomised in a phase 3 trial to the standard of care arm, you'd probably have better outcomes because of that meticulous concierge care by your clinical trials nurse. It, of course, benefits medicine and science and future patients and is an access to new therapies. But it's also important you ask the question of why you wouldn't participate in a trial. It might not be the right question for you. The direct risks are usually relatively easily quantified, but it's often easier just to have standard of care. However, most WM patients have plenty of time to really consider the details and the potential risks and benefits of clinical trials participation. Always consider a trial if it fits well with your treatment goals and that of your community. How we find trials in Australia, we have this neat ClinTrial Refer app that we can identify and identify all the currently recruiting trials, because a patient is not interested in the trial that's closed its recruitment. And with that, I want to remind you that when you pick your poison, please do think about your sequencing of therapy, because I do hope that we are playing the long game in the management of your Waldenstroms. Thank you very much, and I'm very happy to take questions. In fact, I'll be very disappointed if there isn't a single question.
We can't lose this opportunity, people. This is Dr. Judith Trotman. Come on behind me. I'm going to start us off.
Yeah, sure.
We're going to have the joy of hearing from you at the Ask the Doctor panel tomorrow, which Pete and I will be moderating. So I would love to ask you to reiterate a little bit more tomorrow about clinical trials, the why, and we can go through, and because I know you got rushed at the end there a bit, so I just wanted to guarantee that would happen as well. So anybody, here we go. Here's the first brave soul.
What about the sequencing of treatments?
Well, that's why I like to start with immunochemotherapy anybody I can. Because if we start with a BTK inhibitor, and let's say you get 10 years out of your BTK inhibitor, so you've done very well, and many people, I've got patients who have been on zanubrutinib and ibrutinib for, 7, 8, 9 years. You're going to be 10 years older. And if your doctor didn't think you were fit enough and well enough for immunochemotherapy when you were 70, it's going to be a bit harder to get it into you when you're 80. So, we know these wonderful oral enzyme inhibitors, these switch agents, are wonderful agents, but it's good to have them in your back pocket if you're fit enough for chemotherapy.
Good morning. You had mentioned sinusitis in a couple of your patients. I suffer terribly from that. Can you address that at all?
Yeah, I mean, there's the sinusitis because of plenty of people get sinusitis. There's the sinusitis because of the immune suppression from the Waldenstroms and its treatment, and predominantly its treatment. Where the immune suppression from Waldenstroms kicks in, I think, is primarily in its suppression of the production of the normal immunoglobulin levels. And so if a patient has an IgG level of less than 6 grams per litre and recurrent infections or one life-threatening infections, we are allowed to give them immunoglobulin replacement therapy. And the thing about sinusitis is I send them to an ENT specialist so that the ENT specialist really gets them, using their Fess saline drops and, often they need very prolonged courses of antibiotics to really clear out the bacterial infection. Yes, last question.
If you're on a treatment and you find out that it's very effective in reducing the IgM, but it has all these side effects, how do you address the low hemoglobin, the low white cells, the low platelets?
So mostly it's not a low hemoglobin. Mostly you'll see if you've got control of your Waldenstroms, the hemoglobin will come up like a mirror image with the IgM level. The management of the low platelet, the low neutrophil count is very easily done with GCSF injections. So I have a couple of patients who are on venetoclax, for example, who just give themselves a GCSF injection once a week, just to keep their neutrophils above 1. We don't need it normal, we just like to have it above 1. Yeah. Yep. And if you have good disease control, you shouldn't have a problem with low platelets, unless it's an immune problem or if it's because of, you've had multiple lines of treatment and you're needing some chemotherapy agent. Yeah. Sorry, last question.
Okay, thank you. I've noticed several examples where people hadn't started treatment with BR and their IgM levels are somewhere in the 5,000 and more level. And quite often I'd heard that, when you get over 4,000, you need to be concerned. But absent any symptoms of hyperviscosity, what kind of levels are you comfortable with? Yeah. And then just a corollary to that, at what point would you want to, if you're doing BR, would you want to delay the Rituxan on the first treatment just to avoid any issues of flare?
So there's no one answer that suits all. Firstly, I think about the age of the patient, the tempo of the disease, and I have a very good look at their arms, because I actually quite like to give bendamustine and rituximab together, and I will often, therefore, give them when their IgM, if it looks like it's going to happen and your IgM is going to hit 40 or 50 and you're going to need treatment, and it suits you and your lifestyle to have treatment now rather than in a few months' time. I'm not a zealot in terms of waiting to IgM of 60. Particularly now I know I have lots of options up my sleeve for that patient playing the long game. But sometimes what I will do is if they've got really good veins, I will actually do a plasma exchange and reduce their IG. Certainly if they've got symptomatic hyperviscosity, I will plasma exchange them and take the IgM off and then get started. The other thing you can do is you can do a weekly follow-up, and if it looks like they're going to have a flare, because not everyone has a flare, if it looks like they're going to flare, then we just plasma exchange them then. But if you've got a patient with terrible veins, you don't want to be getting yourself into trouble with that. And so that's where I might start the bendamustine and the rituximab later. Thank you. I'm very happy to take any further questions later.